So there's not a lot new in living kidney donation, but I'm just going to give an overview of kind of standards of care and then talk about my own personal experience as well. I don't have any disclosures. The objectives for our talk today, we're going to make the case for living kidney donation. We're going to review criteria for donor selection and how you evaluate your living kidney donor. When we'll talk about the risks of surgery and some other surgical considerations and techniques. So a little bit of history. The first kidney transplant was in 1954, and a man donated his kidney to his identical twin brother, and that man went on to survive till the age of 81. The number of patients waiting for kidney transplant has increased over time. There's about 850 million people currently affected by different types of kidney disorders. And basically, the cadaveric donation supply just does not meet the demand. And so we need to, talk about other sources of kidneys for patients that need a transplant. Living kidney donation has the best outcomes when it's available. And it's really, when it's available, the treatment of choice for patients with end-stage kidney disease. So in 2013, the OPTN implemented a policy requirements for living kidney donors to basically create consistency across sites. What we know is that the chronic kidney disease is on the rise, and it's becoming, it's projected to, in 2040, to become the 5th leading cause of death for our population. So this is going to become a much bigger problem before it gets better. Living donors account for about 30% of kidney transplants performed in the U.S. We saw a 265% increase in the annual number of donations from 1988 to 2004. And then that rate just sort of dropped off for some reason. Then we saw another increase starting in about 2017 to 2019. And that increase in living donors was predominantly related to the increase in unrelated or the paired donor program. The advantages of living donation: you avoid a prolonged wait time for receiving a graft. You're able to time the transplant according to in advance, according to patients and donor preferences. You have increased potential for matching HLA, and patients experience faster recovery. You have greater short-term survival rates than you do with deceased donors. You have improved long-term success with the lifespan for living kidney donation about 15 to 20 years versus 10 to 7 for deceased donors. And deceased donors have an increased rate of delayed graft function. So overall, you get better allograft survival rates with living donors, and those rates are about at 3 months, 98% versus 96%, and at 1 year, 96% versus 92%. The basic criteria for living kidney donation: patients have to have, obviously, absence of renal disease. They have to have a normal contralateral kidney, absence of infection, malignancy, and basically any healthy person can be a potential donor. The risks for the donor must be acceptably low, and the donor obviously must be fully aware of the risks and give informed consent. So it's basically up to the transplant program to define their acceptable thresholds when they're determining if somebody is a candidate for donation. And you take into consideration, the general population, the risk across the board for your demographic, and then as well as the patient's individual risks. So the preoperative evaluation includes a medical evaluation, surgical, radiological, psychosocial, and so you really have to have a multidisciplinary team to tackle all these facets. The OPTN requires blood typing on 2 separate occasions. You have to have a comprehensive medical evaluation by a medical doctor and the surgeon. The psychosocial evaluation can be accomplished by any number of practitioners. And one of the most important key components of your transplant team is the living donor coordinator, or the independent living donor advocate. And you need to respect autonomy for the donor at every phase. And sometimes that even means, giving the donor an opportunity to back out in in a way that they can do so confidentially, maybe declaring that they're not a candidate if they at some point change their mind, so that they don't feel pressured to proceed. The goals of the preoperative evaluation are to exclude any underlying medical problems that would significantly increase their risk of surgery or general anesthesia. You want to, thoroughly evaluate their future risk for, possible chronic kidney disease. You consider their family history, their underlying medical problems. You screen for viral pathogens. And finally, once they've sort of gone through all of that, you get your imaging. Some people will do a screening sort of ultrasound, which is low risk, low cost, to make sure that there's no major contraindications, and then follow that up with a multi-phase. I would say 4-phase CT, you need the non-con arterial, venous, and delayed phase to fully evaluate the anatomy. And you need to ensure that the donor is mentally fit to donate and they understand the risks and that there's no evidence of coercion. You estimate their GFR and you confirm that, and this is, again, one of the OPTN requirements, you confirm that the GFR using an exogenous marker, measured creatinine clearance. You can repeat estimated GFR using creatinine or use a combination of serum creatinine and cystatin C. The preoperative medical evaluation is pretty comprehensive. We're all familiar with this. It's really not much different from how we might assess our normal surgical patients, except for we're adding in the viral serologies, repeating your ABO blood typing in HLA screenings, making sure that they are free of malignancy by doing all of your cancer screenings, colonoscopy, pap tests, and such. Some difficult situations that come up are when patients are advanced age or high BMI. My cutoff for BMI is probably about 33. Some places will go up to 35. It just depends on what you're comfortable with. If patients Jehovah's Witness, I'm not sure some people would feel comfortable, considering them as a donor candidate. Although the actual risk of blood loss and blood transfusion is actually exceedingly low. The question of pregnancy in the future, there's no evidence that it causes any harm, but it is recommended that patients wait at least a year after nephrectomy. They must make an informed and autonomous decision, and given the option to elect not to proceed if they want, and then you have to make sure that there's no financial gain. That would be a violation of federal law. You want to ensure confidentiality. And I was trying to think of an example of that's unique to this situation. We had an anonymous donor a while back who was very interested in how his graft was functioning in the recipient. And we really, don't give out that information and keep it very confidential. The surgical risks, not unlike what we're used to with surgery, hemorrhage, injury to surrounding organs, pneumonia, other infections, ileus, DVTs, PEs. Patients can experience postoperative hypertension, and I'll go a little bit more into that. May experience acute renal failure, incisional complications, mental stress, death. For living donors, this paper looked at the 30-year trends in perioperative mortality. This is really important to consider, even though the risks are pretty low, but there's no direct medical benefit of living donation to this patient population, and we're actually in a sense causing them harm. So you have to take into account what their risks are. So the estimated perioperative mortality rate is about 0.01%, and it's that includes hemorrhage. Males have higher risk than female. Risks are higher with open versus laparoscopic, and they're higher if the patient has history of pre-operative hypertension. And the risk for major complications is about 1.8. Most patients will have blood pressures in the normal range, or if not, it can be easily managed with medications. Late hypertension after donation is about the same as it is for the general population. Advanced donor age and BMI are risk factors for hypertension after donation. And, proteinuria develops in about 13 to 22% of patients. Patients should be counseled about the future conditions that could affect their kidney function. So you want to counsel them to avoid, to maintain healthy weight and lifestyle after donation, avoid developing comorbidities such as hypertension and diabetes and other things that could potentially compromise their remaining kidney. In this study from JAMA, about 96,000 living donors were identified and then compared to a matched cohort of about a little over 9,000 healthy screened non-donor patients. And Compared to the healthy non-donors, live donors had an increased risk of end-stage renal disease. However, the magnitude of the risk was small. And you can see that data here. It was about 3.9 per 10,000 for non-donors and 30 per 10,000 in donors. The overall cumulative risk of end-stage renal disease per 10,000 people at 15 years varies depending on age, race, and sex. So highest risk for people over 60 or if in Black male and Black females. But when compared to the general unscreened population, donors actually have a much lower risk, lifetime risk of developing end-stage renal disease. So we're going to switch over to talking about surgery. Surgical goals for living kidney donation. You want to minimize warm ischemia time. You want to preserve your vessels. You want to completely maximize the vessel length that you're taking, which is sometimes one of the things that can make this a somewhat challenging surgery. And you need to be careful to preserve the ureteral length and ureteral blood supply. So how do you decide which kidney that's going to be donated? Based on your evaluation with your imaging, you look at the vessels. Are there any vascular abnormalities, anomalies, or variants? Are both kidneys normal? Are there any cysts or stones or other things? And which approach is best? How do we want to approach this surgery? You always want to leave your donor with the best kidney. So you want to leave them with the most normal kidney. Which technique is the best? I think I will rarely take a right-sided kidney just because you so rarely find that the vessel length is adequate. But in the event that is, let's say the left kidney is completely normal and the right kidney might have a cyst or a small stone or something, I would do that via an open approach just to maximize my vein and arterial length. My preferred approach is hand-assisted laparoscopic, but all of these techniques are adequate, and we can go through what the differences between those are. In this study, robotic versus laparoscopic versus open nephrectomy for live kidney donors, there were 13 studies that randomized about 1,200 donors, and 7 of these looked at laparoscopic versus open. And the differences were that with laparoscopic, you had reduced analgesia use, shorter hospital stay, the duration of the procedure was longer, and also the warm ischemia time was longer. But overall, there were no differences in blood loss, perioperative complications, or need for operation. There were 3 studies that compared laparoscopic to hand-assisted lap. Again, no difference in analgesia, hospital stay, operating time, blood loss, or perioperative complications. There was a slightly lower warm ischemia time with hand-assisted, but these studies had high heterogeneity, so not much we can say about that. When you look at robotic, that shows that you have longer warm ischemia time with no difference in anything else. The conversion rates for laparoscopic versus hand-assisted are 1% versus 0.6%. Surgical considerations, you may want to consider an epidural or a postoperative tap lock, depending on where your incisions are. There's variability in how patients are positioned. Many people who are doing pure lap will use a right lateral decubitus position with the table slightly flexed. Intraoperative diuresis is promoted with IV fluids. I think it's probably been more than 10 years since I've used something like mannitol or Lasix intraoperatively. And I think the outcomes are fine without it. I've never had a problem. You do want to promote diuresis, especially when you're using laparoscopy to help prevent oliguria associated with the pneumoperitoneum. Upon removal of the kidney, it's placed in slush and immediately perfused with cold solution. If your kidney is going across the hall, you can use heparinized LR. That's about $10. If you're, maybe participating in the paired donor program and your kidney is going across the country, you want to perfuse it with a UW solution, quite a bit more expensive. And then the kidney gets taken off and gets back tabled by the recipient surgeon, Dr. Davis in my case. So this is an illustration of patient positioning, right lateral decubitus and slightly flexed. For laparoscopic, most people will use an extraction site that's a low fan and still incision. Some people who are doing hand-assisted might use that incision as their hand port as well. I think that makes it a little more complicated. This might be, your typical port placement for pure laparoscopic donor nephrectomy. My preference for hand-assisted, I don't flex the table and my patient is not in full flank. They're sort of supine with a gel roll or a bump under the hip and shoulder to sort of slightly tilt them over, and I secure them to the table. And then I can tilt the table to get, the positioning the way I like it. I make a small, maybe 5 centimeter periumbilical incision, and I use that as my extraction site. I have 5 centimeter wrists, so you'd have to make it bigger if you had bigger wrists, maybe. And then you can add a fourth trocar site. Oh, and I like this approach because I can place my trocars like right on top of my hand, so it's like completely safe. I'm not going to accidentally, injure an organ or something with, my trocar placement. Surgical considerations, I already mentioned asking anesthesia due to a nerve block. Preferably, you have an experienced surgeon performing this surgery. You have to know your anatomy perfectly inside and out, like the back of your hand. Be careful with your trocar placement to avoid injuries. Again, I place it right on top of my hand. And you're mobilizing the entire kidney except for the lateral aspect. You don't clip, staple, or cut anything until it's all completely dissected out and you're ready to go. And I got confirmation from the recipient surgeon that the recipient is ready to go and they're open and everything's set up. You, in the course of surgery, you're dissecting the colon medially. You may need to add an additional 5 millimeter port for retraction of the colon if they've got very fatty mesentery, for example. After you've got complete mobilization of the kidney, except laterally, you have the vein dissected all the way basically to interaortic caval or the other side of the aorta as far as you can, and you have the artery dissected down to just at the ostium. If you have any lymphatics, you can consider clipping those. And then the order of ligation is first you clip and cut the ureter. I try to take it all the way down as far into the pelvis as possible after it's already crossed the iliac vessels. And then you can introduce your stapler, staple the artery first at the ostium, and then the vein, again, as far interaortic caval as you can. So you're not allowed to use these Hem-Lock clips for donor nephrectomy. You have to use a stapler. We use them for, radical nephrectomy sometimes, but it's definitely not permitted in donor nephrectomy. This is an example of the stapler that I use. It throws 2 rows of vascular staples, and the amount of vessel that you lose as it cuts is like maybe 2 millimeters. Like you get very minimal vessel loss when you use this, which is obviously very important vessel length for the success of the recipient surgery. Post-operative care, you want to monitor the fluids, electrolytes, and urine output very closely. Control pain. Using ketorolac is okay. You want early ambulation. You monitor patients for post-operative bleeding, wound infections, bowel complications. Patients usually go home on post-operative day 1. Sometimes they stay longer. And, as with any post-operative care, gradual return to normal activities, no heavy or strenuous lifting for 4 to 6 weeks. One conservative follow-up scheme, I usually see patients back after a month, about 4 weeks after surgery, make sure they're okay. They're also following up with the nephrologist, and then they'll see the nephrologist a couple times during the course of the next year. And they're being assessed for their kidney function, making sure they're not developing albuminuria. You're checking their blood glucose and blood pressure annually with their primary care provider, and repeat referral to nephrology as needed. Thank you.